this, then you change the muscles as well, so you don't know which one causing the syndrome. So if it's, for example, here, I would use the hip flexion. If it's just on the back of the leg, you can reduce the hip flexion, or here, you can do that and you change yes, no. For the common, that's the typical straight leg raise. Common peroneal nerve, you come down, plantar flexion, and you change no, inversion, keep it, and up. And it change yes on my foot, down again. If you want to challenge more the sciatic nerve, you can add abduction and internal rotation. So let's say you suspect again a nerve involvement and you are 90 degrees there, your here doesn't change, you can keep it there, move it in abduction and rotate it, so you challenge it further, and again you ask if you don't get your answers. That's the straight leg raise. And the slump, let's see. So the slump, again we look for the knee extension, posterior leg pain. Again, if the symptoms are lateral calf or the outside of the foot, you can use the plantar flexion, common peroneal nerve bias, or the tibial nerve, just the dorsiflexion. So hold your arms behind your back and you change no. Slouch and change no. Bend, so you keep all the components there and you change no. Pull your toes up and change no. Keep them up and straighten your knee and you change. Okay. So if you don't get, and you have a patient that relax, that he gets, for example, leg pain after 3 hours of driving, you will not reproduce it like that. So you need really to challenge these systems. So I would go there, so I will increase the hip flexion, or you can side bend on the other side, so further increase. Or if still you don't get and you're convinced that it's the nerve or it's back related, you can place them in neurodynamic position. Do we have any scale, any chair, maybe? Yeah. So you can block the dorsiflexion, or you can use towel if it's common peroneal nerve bias, or you can ask them just keep it there. So you place it, you can combine this in neurodynamic position, or telos if you want to increase the hip flexion. So they are there, and you go on the back. And usually in this type of presentations, an AP will not be enough. So you go and you press, sustain pressures, you keep it 30 seconds, sometime 1 minute. Tell me if something changes. So possibly it will change, but you need really to challenge. So you can't go caudally, set, and then you can go on the transfer process like that. So it's useful sometimes to combine to place in the neurodynamic position and palpate if you don't get, and if you see on the subjective that it's not going to be easy. Okay, that's the test. Any questions? Anything? I don't know.
What would the glide do to it?
So with the glide, you just explore the back. If it's back referred, it's more combined. So
just like you do your manual assessment.
Yes, exactly. So if you think that it's radicular back related, you just challenge it more, spinally referred, but it might not be. Same with the piriformis, you can place in the modified, actually this is interesting. The modified straight leg raise will challenge even further. You will have the trunk as well. So if you lie on your side for me, let's say you have someone with piriformis syndrome, you have checked your lumbar spine movement, combined, everything is normal, and you're bending, so you can go there. That's it. So face your bottom leg straight. Okay, so you can go there. Again, you add your components. So I won't straighten it out. You can play with the head there, but be careful if, so her head now, can you put it there? So be careful, it shouldn't be in side flexion because you will change things up there. So you can put it here and block it or further flexion, and you go and palpate. So if you reproduce here where the piriformis is, sometimes then you can do an interface there. It's difficult for the patient to do it by at home, but sometimes it's the only marker we get. So sometimes might be useful. Okay. And something for the end, for the assessment. So if a test is positive, it doesn't really tell us where is the injury, the lesion. It just tells us that the whole neural tract loaded. It's just sensitive to mechanical tension. It might indicate that it's more distally or more proximally, depending on the distribution of symptoms. But of course, it's not diagnostic. Okay? So shall we do a break and then carry on with the treatment?